Welcome to today's webinar, Health Insurance Exchanges and the Potential Impact on Minority Populations, brought to you by NCSL. At this time, all lines have been placed on a listen-only mode to provide favorable sound quality during today's presentation. It is now my pleasure to turn the floor over to Martha Salazar. Ma'am, the floor is yours.
Good afternoon, everyone. I'm Martha Salazar, and on behalf of the National Conference of State Legislatures, I would like to welcome all of you to today's webinar, Health Insurance Exchanges and the Potential Impact on Minority Populations. This webinar is the second in a two-part series on health disparities. An archive recording of the first webinar related to social determinants of health is now available on NCSL's website at www.ncsl.org. These webinars are part of NCSL's ongoing Health Disparities Project. In its third and final year, this project has created many evidence-based resources for legislators and legislative staff. Today's webinar will discuss how health insurance exchanges may impact certain populations and what 2 states are doing to address this. We are very fortunate to have 3 experts joining us on today's webinar. Chiquita Swisher from the Federal Office of Health Reform, Katie Marsalis from the California Health Benefit Exchange, and finally, Senator Renee Unterman of Georgia. Our first speaker, Ms. Swisher, is here today to share her expertise as a Director of Coverage Policy within the Office of Health Reform at the U.S. Department of Health and Human Services. The Office of Health Reform provides leadership and coordination of the development of the administration's policy agenda across agencies for the Affordable Care Act. Within OHR, Chiquita is responsible for policies regarding consumer protections, exchanges, and Medicaid coverage. Prior to joining HHS, she was Democratic staff on the Ways and Means Committee. There, she played an important role in the passage of the new healthcare reform law, working on issues related to healthcare coverage, Medicare Advantage, and Part D. Prior to joining the committee, Chiquita was a director at the Avalier Health, a group that advises clients on health policy. From 1999 to 2003, she worked at the Office of Management and Budget, where she advised OMB and White House policy officials on Medicaid and S-CHIP waivers, the uninsured, and Medicaid reform. Chiquita received her AB from Princeton University and her MPP from Georgetown University. Chiquita will not have a PowerPoint presentation today, but we are excited to hear her speak.
Thank you. It is really a pleasure to be with all of you today and to talk about such an important topic. As we know, persistent health disparities exist between different racial and ethnic populations, and health equity remains elusive. Racial and ethnic minorities are less likely to get the preventive care that they need to stay healthy. They're more likely to suffer from serious illnesses such as diabetes or heart disease. And when they do get sick, they're less likely to have access to quality health care. 56 million Americans do not have regular access to a doctor for their routine needs. More than half of the nearly 50 million people who lack insurance are minorities. African Americans, Hispanic, Asian American, American Indian, and Alaska Native populations suffer higher mortality rates than other populations. For example, cardiovascular diseases account for the largest proportion of inequity in life expectancy between African Americans and non-Hispanic whites. Several provisions of the Affordable Care Act, which passed Congress in 2010, will help reduce disparities. One of the most significant is what we were talking about today, which is health insurance coverage. Health insurance coverage is a critical element to make sure that individuals and families have access to the care they need. The Affordable Care Act establishes exchanges, which are marketplaces where individuals who qualify will be able to purchase insurance coverage. Each state may elect to establish an exchange, run part of an exchange through a partnership with us, or the HHS Secretary will establish an exchange for that state. Exchanges will increase access to coverage by providing a single point of access for consumers to receive eligibility determinations for enrollment in the exchange and for insurance affordability programs. Exchanges will also increase competition among issuers by permitting consumers and employers to easily compare plans that meet minimum quality and other standards. Individuals with incomes between 100 and 400% of the federal poverty level who do not have access to affordable coverage from their employers and who meet other eligibility rules will be eligible for premium tax credits to reduce the cost of purchasing health coverage and will help with the cost of their premiums. Those below 250% of the federal poverty level may also be eligible for assistance with the cost of copays for services such as going to the doctor or the hospital. Coverage through the exchanges will begin in every state on January 1st, 2014. These and other improvements to our healthcare system under the ACA are critical to reducing health disparities. But outreach and education to all populations is going to be critical to really reducing and ending health disparities. So next, I'm going to focus on the outreach efforts across the department. I'm going to start by talking about the outreach that the Office of Minority Health is spearheading, and this is ongoing right now. The National Partnership for Action to End Health Disparities is the first national, multi-sector, community and partnership-driven effort to address health equity developed by our Office of Minority Health. More than 5,000 individuals participated in the creation of this partnership on behalf of community and faith-based organizations, businesses, healthcare and insurance industries, as well as academia, state, local governments, tribal governments, and other sectors. Based on this input, 5 specific goals were outlined in the strategy to achieve health equity, along with 20 collaborative and community-driven strategies. The overarching goals include increased awareness of health disparities, their impact on the nation, and the actions necessary to improve health care outcomes for racial, ethnic, and underserved populations, strengthen and broaden leadership for addressing health disparities at all levels, strengthen the healthcare system and improve life experience for racial and ethnic and underserved populations, improve cultural and linguistic competency and the diversity of health-related workforce, improve data availability and coordination, and share research and evaluation outcomes. 10 regional health equity councils have also formed within the 10 regions within HHS across the country to provide a regional structure for engaging states, tribes, and communities in the implementation of this partnership. The councils include approximately 35 individuals from the private and public sectors representing communities that experience health disparities, state and local government agencies, tribes, healthcare providers and systems, plans, businesses, academic and research institutions, foundations, and other organizations. The 10 regional offices are currently engaged in holding their annual technical guidance meetings that include the participation of a wide range of folks to show what a priority focus we have on these meetings. I'm next going to focus on outreach with minority communities that specifically relates to the Affordable Care Act. Since the Affordable Care Act passed, our strategy has been to communicate with beneficiaries about new programs and benefits as they become available, such as the Medicare donut hole coverage, preventive benefits, cancer screening, and the exchanges. We know that the audience is diverse and we need to serve multiple languages and cultures. We communicate with beneficiaries in a multifaceted ways, directly through new and expanding paid and earned media channels and trusted partners. We nurture close ties with national Hispanic, Asian American, Pacific Islander, African American, and faith-based organizations on a national level to ensure that these communities leverage HHS tools. Our regional offices provide tremendous support for these efforts across the country to ensure that outreach reaches grassroots level. Almost 2,000 events and activities have occurred in the regions this year, and well over 66,000 people received important information that we had to share. Just want to highlight a couple of important initiatives. Prevention is such a key piece of healthcare disparities, making sure that people have access to the care that they need. In June and July of this year, we ran a preventive benefits campaign that targeted Hispanic and African American and other audiences. The Affordable Care Act now covers preventive services and a new wellness visit at no or reduced cost, as well as providing discounts on brand name drugs in donut hole coverage. It's our job to ensure that everyone who's eligible for Medicare uses these benefits. Prevention is also, these services are also being covered in non-grandfathered private plans. National television and public radio public service announcements were created to highlight the enhanced benefits from the Affordable Care Act. The Hispanic campaign focused on the top 7 Hispanic markets: Chicago, Dallas, Houston, LA, Miami, New York, and San Francisco. The African American campaign targeted the top 25 markets based on population. The campaign for Asian American and Pacific Islanders ran in key Chinese, Vietnamese, Korean markets all over the country. We recently announced that during the first 6 months of 2012, over 16 million people enrolled in Medicare have used the preventive services with no cost to them. And also, nearly 1.3 million people with Medicare have used the annual wellness visit to discuss with their doctor or healthcare provider. As we started and focused on exchanges, we're moving forward, and exchanges won't be implemented, as I said, until fully implemented in 2014. Our job now is to continue to work together as we build our programs to educate and inform consumers of what's to come, the options that will be available to them, and to motivate them to enroll in coverage. A critical piece is going to be not only making sure that these marketplaces are available and able to help consumers, but that they are aware of them, that they understand how insurance coverage will work, and understand all of the options that are available. As we think about outreach and education, we are putting in place a strategic framework to help promote new and existing health insurance coverage opportunities to the uninsured and all who stand to benefit. We are using research to inform strategies and tactics to motivate individuals to seek out new coverage options and complete the application enrollment process. One of the ways we intend to identify target audiences is through a user-friendly resource that was created by the research office within our department that allows us to use census data to target outreach to the uninsured. The goal is to provide useful information for ACA, the Affordable Care Act, related outreach in the form of maps and sortable online spreadsheets. This data is live on the HHS CMS partnership page and provides statistics on the uninsured at the sub-state level, known as PWMA or PUMA. PUMAs are areas with at least 100,000 people. You're now able to view and sort data identifying geographic locations of uninsured populations, as well as filter or sort the data on several population characteristics, including age, race, and ethnicity, federal poverty level, education, and language. We know we'll need to do a lot of education with consumers to help them understand the basics of health insurance and what it means and how to use it. We'll also need to prepare them to enroll in coverage, having any needed family information or paperwork available that they may need to complete the process. We anticipate that this message will evolve over time as operational details are available and as we transition over time to when consumers can actually take direct action themselves and enroll through the exchanges. As we know more about our audiences, we'll plan specific tactics to reach them but would anticipate that there'll be a mix of ways in which we try to reach consumers. The 2014 really will offer tremendous opportunity as exchanges are up and running and people are able to buy coverage and receive financial assistance through tax credits if they qualify. Individuals will no longer be discriminated against because of their health status or gender or other forms of discrimination that currently exist in the market today. And through increased access to care, because again, as people have access to insurance, they're far more likely to see doctors and providers and get the care they need. That will be one way in which we can all work to reduce racial and ethnic disparities. So with that, I'll stop, and after we've heard from the other speakers, be happy to answer questions.
Thank you, Chiquita. Our webinar today will conclude with the question and answer sessions. Please note that you will not be identified when you ask a question, nor can other participants see what you have typed in the chat box. As a reminder, you may submit a question at any time by typing in the chat box on the right-hand side. We will also be sure to post the PowerPoint presentation on the NCSL website with an audio archive of the webinar. Our next speaker is Ms. Marsalis, who will discuss how California is addressing reaching populations in the California Health Benefit Exchange. As the Director of Program Policy, Katie administers and oversees statewide program policy and coordinates with state partners, including health programs and regulators, to lay a foundation for implementing the Patient Protection and Affordable Care Act for the California Health Benefit Exchange. Prior to joining the exchange, Katie served as an Assistant Secretary at the Health and Human Services Agency with responsibility for healthcare service programs. Katie, you may take the floor.
Thanks so much, Martha. Can you hear me?
Yes.
Excellent. Let me move my slide here. I'll just pick up a little bit where Chiquita left off on establishing exchanges. California established our exchange in 2010, and we've been working aggressively to implement, to get ready to begin open enrollment October 1, 2013. One of we kind of talked about three fundamental areas of work. One is getting folks enrolled, so we're working to build an eligibility and enrollment system that will make that a consumer-friendly, very easy process. Another one is having affordable plans to offer, and then the third piece is doing the outreach and education so that we can maximize enrollment, and I'll focus most of my remarks today on that. I just want to start with the vision and mission statement and values for our organization. California, as you know, is a very large, very diverse state, and we consider it critical to our mission to serve all Californians. And as you can see in our mission statement, I won't read it to you, but it does include reducing disparities, which we know we have, as an exchange, we have a major opportunity to do that through, as Chiquita said, getting folks enrolled, but then also through offering high-quality coverage that really allows us to meet those needs. Here you can see our values. I won't read them to you again, but I just highlight a few. We always strive to put the consumer first, so we are consumer-focused, and we recognize that we have diverse cultural, language, economic, educational, and health status needs for the people that we'll serve. We're looking to do a majority of our outreach in 13 threshold languages that our state Medicaid program uses. So we want to make sure that we're speaking to all of our eligible populations in a manner and a language which makes them most comfortable and most likely to enroll and access services through us. We want to be a catalyst for change. Broadly, we want to provide high-quality, affordable health care, and we want to use that to reduce disparities, including promoting prevention and wellness throughout our plan design. We value integrity, including transparency, so we seek to make everything that we do available to our stakeholders. and we focus on results. So we want to improve healthcare quality, we want to promote better health and health equity, and we want to measure that. So one of the things that I won't spend too much time on, but we're looking to develop an evaluation plan for the exchange, and we'll be measuring ourselves across metrics in terms of how we do for different racial and ethnic groups. We want to make sure that we're holding ourselves to account so that we are serving all of Californians and all of our eligible populations in a way that is equitable. So let me just move to a little data. Here you can see our exchange subsidy eligible adults by race and ethnicity. So you can see we have a plurality of our eligible individuals will be Latino, followed by white, Asian Pacific Islander, African American, and other. As you can see, obviously quite a large state and very diverse. In terms of spoken languages, 40% of our eligible speak English, 41% speak Spanish. That means 20% speak other languages. So we know that it's very important for us to have a diverse approach to communicating with our eligible individuals. So I'll spend the remainder of my talking about some of our targeted outreach strategies. One of the things that we started early on was developing a marketing outreach and education sort of report, which is available on our website for anyone who's interested. And the website address will come up in the next couple of slides. So the report lays out a strategy for our outreach and education efforts through 2015. Some of the guiding principles for our outreach and education efforts are to use marketing and outreach strategies that reflect and target the mix and diversity of those who are eligible for coverage. So we want to make sure that we're appropriately targeting all of our efforts to our diverse populations. And we want to consider where eligible populations live, work, play, and pray. So we want to use the tactics and the media channels that will help us best reach all of our target populations and encourage them to enroll, and once they're enrolled, to retain coverage. So this marketing plan lays out our efforts across a variety of domains, including research and measurement. So one of the things we want to start with is some very detailed market segmentation work that's starting now. So I presented our sort of high-level demographic information, but we want to make sure that we're looking into all subpopulations so that we have the appropriate market segments so that our marketing efforts will be most effective. We'll do creative development so that we get the right messages to speak to the right communities. We'll do paid media, public relations. We'll have a very robust digital strategy. We'll do quite a bit of work with partners, community partners, and then we'll do events. And this all sort of rolls out in 7 phases that are described in the report that's on our website, and I won't go into them too much, but we are looking to start our consumer outreach and education at the beginning of 2013, and then we'll move to sort of a get ready, get set, enroll starting in July of 2013. So let me move to some of the specific strategies. We know that our ethnically diverse populations will require specific and targeted outreach. And we know that language barriers, cultural differences, health literacy, and socioeconomic status all have contributed to the challenge of securing and maintaining coverage for diverse populations in the past. I want to say it's very important to us. We don't consider this a niche or an add-on. This is sort of baked into our entire plan that we need to be working with critical paid media, earned media, providing grant support, so that we can reach our diverse populations. We'll focus on the Latino population, African American, Asian Pacific Islander, and Native Americans, but we're also developing plans for some of our smaller target cultural groups, including efforts in Russian, Armenian, Farsi. One of the things that we strive to do is to share our work with other states. So we consider California can be sort of a testing ground for messages in some of the languages that may be very important to certain states, but the state may not have sort of a critical mass of population to be able to do targeted research and messaging. So we look forward to sharing the work, the development work we're doing for outreach and education with other states so that they can reuse that material wherever possible. So let me just, I'll go back to the slides here and pick up on some of our targeted outreach efforts to Latinos. As you can see here, Latinos represent more than 37% of California's population, about 50% of our uninsured. Spanish language dominant make up about a quarter of our population, and we have about 60% bilingual, and then 17% that are English only. Some of the strategies, the partnership strategies we're exploring are Spanish language media, including broadcast and print media, working with healthcare providers in community clinics, both to do outreach and to do actual provider-based enrollment, working with our promotor groups and other community programs to share the word about the exchange and the coverage opportunity, working with community-based organizations to provide them grants for outreach and education, to train them to be to provide in-person assistance, working with faith-based organizations, and then with our schools. Moving on to Asian Pacific Islanders, quite a diversity of this population in California. They represent about 12% of the population in the state, about 10% of the uninsured. So sort of a similar mix of partnership opportunities here. In developing the report, we looked across the groups to see what figures would be, the populations would be most receptive to hearing outreach from. So here we have, in addition to community-based organizations and faith-based organizations, influencers in the communities, medical centers, medical groups, and clinics. We want to look at Young Invincible events. So some of the novel ideas that were raised here included car shows, karaoke bars, casinos. So we're looking to have quite a broad strategy and use events where we know that we can get good sort of penetration with the Young Invincible population. Outreach to small businesses and celebrity spokespeople. When you sort of drill down into the target populations, some populations seem to be more receptive to celebrity speakers versus elected officials versus sort of community leaders. So in our next round of fleshing out this marketing campaign, we'll be looking at what spokespeople are best for each community. African-Americans, so 6% of California's population, but 15% of the uninsured. We want to make sure that we maximize their enrollment in the exchange, as Chiquita mentioned, population suffering disproportionately from preventable chronic diseases, and we really want to use the exchange to reduce those disparities where we can. Again, you can see the sort of list of target partnerships that we'll explore in the next several months. And then finally, in terms of Native Americans, we have about 152,000 uninsured Native Americans, or American Indians and Alaska Natives in California. We know that they report delaying or not getting medical care that they need. And we estimate that about 80,000 will be eligible for premiums in the exchange. We're working with tribes, with health programs to flesh out sort of what the best marketing and outreach strategies will be to reach the Native American population. We have engaged in tribal consultation. We're developing a tribal advisory group, and one of the main topics that group will take up will be outreach and education. So with that, here's our website. The outreach and education report is available on our homepage, and I will stop and be happy to take questions at any point.
Thank you, Katie. As a quick reminder, the audience may ask questions via the chat box on the right-hand side, and you can ask questions at any time during the presentation. We will have a Q&A session at the end. Our third and final expert for today is Senator Renee Unterman, who will give us an update on Georgia's actions related to today's webinar topic. Throughout her 22 years as a public servant on the local and state government level, she has focused on health and social law, consumer issues, and has given special attention to the young and vulnerable, as well as the elderly citizens of Georgia. First elected as the mayor of Loganville, she then went on to serve 4 years as a Gwinnett County commissioner. She served as chairman of the National Association of State Legislatures Committee on Human Welfare, honorary chairman on the Hunger Initiative, and has been a member of the American Legislative Exchange Committee for many years, serving on the Health Committee. Senator Unterman now serves as chairman of the Health and Human Services Committee and vice chairman of Regulated Industry and Utilities Committee. She is a native Georgian and has lived in Gwinnett for many years, currently residing in Bedford. She represents the 45th district in her state. At this point, I will turn the floor to Senator Unterman.
Thank you, Martha. It's a pleasure to be with NCSL, and I especially want to thank the NCSL staff for our health committee that we had in Chicago. Y'all did a fabulous job, and all the legislators learned a lot. We're going to start off with the first slide in talking about the 2012 legislative session. I think the state of Georgia is on the opposite spectrum of California, and we have a different viewpoint of the Affordable Care Act and also on the health exchanges. You have to understand the state of Georgia is a Republican red state. We have a Republican governor. We have almost a supermajority and probably will have supermajorities in our House and Senate General Assembly, and all of our constitutional officers are Republican. With that said, the state of Georgia has not passed any legislation to establish a state health insurance exchange. Next slide. Georgia is one of 28 states that fought in litigation to be against the Affordable Care Act. And we have also, as legislators, passed numerous resolutions opposing the Affordable Health Care Act. And the governor has actually signed into law opposition to individual mandates as a result of that. Next slide. As we know and as we found out in Chicago and learned about, that states must submit plans on exchange operations by November 16th. Our particular state and the governor are waiting on the November presidential elections because we feel like it has the opportunity to be overturned. We did sign into law the Interstate Health Compact Bill in 2012, and one of the things that we also passed in 2012 was the out-of-state policies for in-state sale, and I checked with the Georgia Insurance Commissioner, and there has been no one to take advantage. No insurance company has taken advantage of that particular policy to allow an out-of-state insurance company to come into Georgia. And as where are we today in Georgia? As you all know, we're supposed to pass an essential health benefit benchmark plan by September 30th. The state of Georgia does not have that in action, and we do not plan on having that available. Currently in the state of Georgia, we serve a little over 1.5 million enrollees in the Medicaid, and that has gone up during the recession. Georgia is one of the worst hit states, along with Nevada and Florida, because of our dependence on the construction industry. And we've had increased numbers in food stamps and Medicaid enrollees. We go back into session in January. We're in session January through April, and we are facing a $300 million Medicaid deficit that we have to address before we can do anything. And our position is, how can we expand Medicaid when we can't afford the people that we already have on it? We have implemented managed care in Georgia, and we're considering expanding that into dual eligibles. It has been a successful program. Next slide. Our plan of action options, we're waiting till after the November elections to see what happens in the presidential campaign. We're continuing to oppose the Affordable Care Act. We do, if the Democrats win and it does go into effect, we would have an executive order in November, and then we would come back into session in January and ratify legislation for creating the exchanges. So I guess your question is, if we're so opposed to the Affordable Care Act, what are we doing for minorities? And I went and looked at some of the programs, and I'm going to highlight two of the programs that we have specifically targeted in Georgia. We do have an Office of Minority Health. It's an advisory council appointed by the governor. It was housed in the Department of Community Health, and in the last 2 years I wrote legislation and created a new Department of Public Health, and that council was moved into that. We changed the name to Health Promotion. And I'm going to talk about today two example initiatives, Infant Mortality Rate Project and also Minority AIDS Initiative. Next slide. On the Infant Mortality Project, as you probably already are aware, especially the folks on the federal level, that we have one of the highest rates in the nation in the southeast states. The highest racial and ethnic differences are in the South because of non-Hispanic, Black, Puerto Rican, American Indian, or Alaskan Native. Next slide. Infant mortality in Georgia between 2002 and 2006, an infant died every 7 hours and 36 minutes. 5,743 Georgia babies died before their first birth. The Georgia IMR rate was 15 to 20% higher than the national average, and the Georgia IMR was 42% higher than our expected 2010 goal. And part of that reason is because of Black non-Hispanics experienced a higher MR nearly 2.5 times higher than white non-Hispanics. So what are we doing to improve that? We have acknowledged that we have a severe problem with this, and in 2010 we started a new program where we are targeting zip codes and looking at pockets where we have the highest infant mortality rate. And we've already seen changes. First, we had to identify what was causing the higher rates, and one of the things we found was genetics and also deformities at live births that died within 1 year. Next slide. Very pleased to say that from the Federal Department of Health and Human Services that as of this week we received a $1 million grant. We had approximately 1,800 people who were on a waiting list waiting to receive medication to be able to help with their HIV. The Minority AIDS Initiative funding for care and prevention is a U.S. demonstration project, and it's administered through the CDC, and we're very proud of that because Atlanta is the home of the CDC. This project targets racial and ethnic minorities with HIV and diagnosed infections. And it also brings in folks that had entry into the system and bring them back in if they were on this waiting list or they were denied services, and especially reaching out to newly diagnosed racial and ethnic minorities with HIV. We're very grateful that we're able to get our waiting list down to 0 and with the help of the federal government. Two programs that we're also addressing that I did not put on a slide that I'm very interested in, and the Senate and House Health Committees, is obesity and obesity in minority populations, and especially children. And we are working on that and have been working with that through the Hunger Partnership within NCSL over the last 2 years. The other project is addressing lupus in the minority populations. And with that, again, it's my pleasure to be on this NCSL webinar, and I'll be glad to answer any questions.
Great, thank you. And I would like to thank all of our excellent speakers, Ms. Brooks LaSure, Ms. Ms. Marsalis and Senator Unterman. Now we are going to open the floor to questions. If you have not submitted a question yet and would like to, please do so by typing in the chat box on the right-hand side of your screen. We'll begin with the question for Chiquita. Will the health exchanges require the same level of preventive services, care, and cost as Medicare?
What exchanges who are private plans operating in 2014 will need to provide is similar to Medicare, but there are some differences. It's based on a provision of the Affordable Care Act that is already in effect, and that is the prevention services that certain plans in the market today need to provide. And in 2014, plans in the exchange will need to provide those benefits as well. That's what we've said in our guidance about essential health benefits. Those include things like screening for obesity, blood pressure screening, counseling, tests to screen for high cholesterol and diabetes. Those that I just mentioned are things that would be available without cost sharing. Preventing breast cancer, cervical cancer, tobacco cessation interventions, annual mammograms. These are the types of services that will be provided. There's much more information on the CCIO website which is www.hhs.gov/CCIIO.
Thank you. Our next question is for Katie. Katie, you mentioned that they hope that the state of California can serve as a research for outreach efforts in alternative languages. Is this something that's available right now? And if so, how would one go about finding those resources?
It's not available right now. We are definitely in the planning and development phase. You can find our planning document, our overall report on our outreach and marketing efforts. That's on our website, as I mentioned. In the next several months, we'll be figuring out our target, all of our target audiences, and then we'll move into development of materials early in 2013, and we would be more than happy to share those with any states. And Martha, we can work together to see if how we might share that information with the NCSL group.
That sounds great. For Senator Unterman, the question comes in as, what has CCIO said about Georgia's blueprint due on November 16th? And has it mentioned anything about it being submitted without exchange legislation having been passed?
I'm not sure I know the answer to that question. I'm not aware of the Fed saying anything to us. And when I was in Chicago at NCSL, I did not hear of any other states. When we got up and gave our individual reports from the states, I did not hear any questions asked about that, so I don't know the answer.
Okay. Katie, this is another question for you. What workforce increases or strategies does California anticipate that will be needed to enroll all of the newly eligible?
We've estimated that we may need about 30,000 individuals providing in-person assistance. We strive to have a very user-friendly website that allows people to go from creating your account all the way through plan enrollment without assistance. But we do know that some populations will need assistance maybe the first time they're applying for coverage. There'll obviously be choices about plan design and benefit tier and what the subsidy means for them. So we are right now looking to develop our in-person assistance strategy. We have a report on that, which is also available on our website. We're looking to use a variety of groups, including community-based groups, community clinics. We're looking to partner with some of our state entities, including our Employment Development Department and our Department of Motor Vehicles, as well as private partnerships with some major retailers, major pharmacies, so that we can get that workforce to provide in-person assistance so that we can reach people where they live, work, play, and pray.
Great. Katie, as a follow-up to that, has the Health Benefit Exchange determined how navigators will be used to help enrollees, or will they be used?
Well, we will establish a navigator program. The assisters is a term that we use more broadly, which encompasses those who will be paid as navigators and those who won't. We assume that there will be some organizations that will provide enrollment assistance that won't meet all the criteria of being a navigator, or we might not want to pay because they have, certain conflicts of interest. But we would definitely want to leverage them to provide assistance with enrollment. So assisters is sort of our catch-all term.
Great. The next question is for Chiquita. We have an audience member hoping that you can repeat some of the information on how to access the PUMA data.
Certainly, and I didn't mention the website, but that's probably the easiest place to look for the data. It's www.cms.gov/outreach-and-education/marketplace.index.html. And I'm happy to provide that to NCSL, and they could provide that to folks if you want to see it in writing. But basically, just go to the CMS website and click on the outreach section, and that's where you'd be able to find the data. I also wanted to go back to the question about the blueprint and how the department is looking at applications for establishing exchanges. As I think you all know, the blueprints are due November 16th of this year, and in the blueprint, states are showing that if they're interested in establishing an exchange, that they will be able to have it operational for the coming year. It needs to be up and running before January 1st because there are many things exchanges are doing, is certifying plans and getting ready for open enrollment. What we have said is that if states do not have all of the legal authority that they need to establish exchanges, and that is something that we leave to state law to determine, that they can put that in their application and say they are working on obtaining authority. But what we're looking to see is that the state is going to be able to meet all of the requirements to run an exchange so that it works for consumers and small businesses.
Thank you. Our next question is for Senator Unterman. If the election does not allow for the repeal of the ACA, is it possible that Georgia may reverse its decision and expand its Medicaid program?
Yes, I believe it is possible. Like I said before, the governor ruled that he would not be in favor of expansion, but I think it's really all dependent upon what happens in November.
And Chiquita, is it possible to get the website typed into the chat box so that we can send it out to all of our audience members?
Sure, I'll do that right now.
Great, so we will have that available for everyone in the chat box. Our next question is also for you, Chiquita. It's what is the role of regional health equity councils, as you mentioned in your presentation?
They are performing, so basically the councils are in all of we have regions, the country divided up into 10 regions, and really it's the structure to get advice on the National Partnership for Action, which I was talking about, which is really looking at the ways that we can increase awareness and strengthen leadership to address health disparities. So there are councils that are providing input into the national stakeholder strategy.
Great. Our next question is for Katie and is a follow-up to some of the navigator issues that you were discussing. Has California decided how they are going to pay for the cost of navigators?
We're exploring using a pay-per-successful enrollment methodology. So if you look at the report, you'll see that we're proposing a $58 payment per successful enrollment. And the $58 maybe sounds overly precise, but we have done some calculations about the time and the cost it would take to enroll individuals. So for assisters, we are looking at that at $58 per successful enrollment. Some of the issues we're trying to work through, of course, as everyone is how you fund navigators in the initial years when you can't use establishment funds. We're also trying to work through what the payment would be for an assister who winds up doing an enrollment for our Medicaid or our CHIP program. When we, sort of a California-specific nuance, we have legislation that sort of requires that any fees you collect, including the fees that we would collect from qualified health plans, have to be used very specifically for the purpose for which they're collected. So that we think that paying navigators for Medicaid or CHIP enrollment might open us up to a legal challenge on those grounds. So we're trying to figure out how, if we can, compensate for assisters to enroll into those programs. We want to, our general outreach and education strategy is that we want to maximize enrollment in all of our programs, including Medicaid and CHIP. So, and we do have a no wrong door philosophy both for our enrollment portal and for InPerson Assistance. So we don't want to have to send someone to a different entity just because they're Medicaid or CHIP eligible potentially. So those are some of the issues we're working through there in terms of funding.
Great. Our next question is, would Medicaid enrollments be counted as eligible for the 58 Commission? If not, how will California avoid misdirection for Medicaid eligibles into exchanges?
So I think that gets to what I was just saying. We are trying to figure out whether that's something that can be compensated or not, and whether that's something that maybe our Medicaid or CHIP program would pick up. We're fortunate to have some excellent foundations, healthcare foundations in the state. So, we've been in discussions to try to see how we could leverage additional funding sources.
Great. And I believe that we have addressed all of the questions today from our audience. I will also have the website that Chiquita mentioned on our website in case there are any issues with it today. Again, the webinar archive will be available to registrants and on our website. The archive will be available within the next week, and if you have any questions or would need more information, the websites are available on this page. Thank you all for participating in today's webinar.